感谢主席的介绍。今天能在北京与各位谈到这个重要的话题，我感到非常荣幸。Metabolic Bariatric Surgery, or MBS, is the most potent obesity treatment options that we have. And depending on the types of surgery or procedure performed, average, the mean weight loss is about 15 to 35%. Despite the high efficacies of MBS from the Swedish Obese Subject Trial, or SOS trial, which spanned across 20 years, we can see some form of weight regain over the years. But don't worry, it's still not back to the baseline. Patients still have some net weight loss, but there's some concern there. In another study looking at weight recurrence after gastric bypass, the researchers found that with every 5 years post-operatively, the percentage of weight regain from the maximum total weight loss will double across every 5 years. For instance, for the first 5 years, patients may regain back 20% of their maximum total weight loss, and from 5 to 10 years, patients may have 40% of total weight regain, and finally, more than 10 years, some patients may regain up to 80% from maximum total weight loss. Given the significant risk of post-MBS weight recurrence, it becomes crucial to have a way to track and define this. Therefore, IFSO defines recurrent weight gain as more than 30% of weight gain after the maximum total weight loss. So at the maximum total weight loss, patient regain more than 30%. But it's important to know, after 3 days in this Congress, that we treat obesity is not all about losing weight and number on the scale. It's more about gaining health. And what better example of health gain than reducing the risk of serious cardiovascular or CV events like stroke, heart disease, heart failure. In fact, MBS, specifically gastric bypass in this study, has shown to significantly reduce the CV risk over 8-year period. The challenge is sometimes when you tell patients you have reduced risk of getting heart attack, stroke, they may not see it up front. The effect is not visible for them right at this point of time. While they may not enjoy the benefit up front, but the MBS definitely will reduce CV risk related parameters control. So when we do metabolic bariatric surgery, we want the diabetes better control, remission of hypertension, and also high cholesterol level. All these parameters, when you check the calculators about CV risk scoring, they are all present. So these parameters controls have more direct meaning to the patient. And we do know that controlling this will also benefit the patient health for long term. 这个三高是我们的 target when we treat obesity. Just as weight recurrence is a concern after MBS, we must also acknowledge that obesity-related complication, the San-Gao I mentioned, will also recur over time. So we hear a lot of cases, good cases, that after MBS patients, diabetes got into remission, but over the years, maybe 5-7 years, they may have recurrence. So here are the charts showing you that it's true, it happens. Other than weight recurrence, the recurrence of obesity-related complication also happens. Specifically, you can see recurrence of dyslipidemia and hypertension are more than diabetes. So these are the things that we need to take note. Therefore, apart from weight gain, to define recurrent weight gain, IFSO also added that we should consider the definition of recurrent weight gain when there's a worsening or relapse of obesity-related complications. So the question is, why recurrent weight gain, be it about weight or the obesity-related complication happens over time. As we know, MBS is a very potent obesity treatment options. They manage the disease biologically through neurohormonal changes that subsequently reduce the weight set point in our brain. Nevertheless, humans are truly a complex beings. We have so many challenges in our life, and we have multiple obesogenic environments trigger, like high stressor, inadequate sleep, ultra-processed food, and we may have underlying medical conditions that use medication that sometimes causes weight gain. So all these external factors is affecting the MBS power in managing weight. So patient may not be able to achieve the maximum weight outcome or even the remission of their underlying disorders from these important interventions. On top of that, when we lose weight, our body will sound an alarm because of metabolic adaptation. It is a defense mechanism to ensure our survivability. When start to lose weight, our body will increases hunger hormone, reduces metabolism, and also reduces satiety hormone. Therefore, all these collectively making weight maintenance after weight loss difficult and weight gain so much easier over the long run. This metabolic adaptation is applied to all obesity treatment strategies, but to a lesser extent for MBS. So what we see is that if we use lifestyle intervention, the effect of metabolic adaptation is much higher as compared to bariatric surgery or OMMs. Besides obesogenic environment and also metabolic adaptation, obesity, just like any chronic diseases such as diabetes, hypertension, it progresses over the year. It can be because of aging, as shown in this chart. So without any intervention across our timeline, as a human, we may gain more weight. So patient undergone MBS, reduce good amount of weight, but similarly, it will catch up with this line that we will gradually gain weight. But biologically, after MBS, we are already different, so we will never reach the baseline in most cases. Ladies and gentlemen, recurrent weight gain is rarely due to surgical or patient failure. I always tell my patient, whether they are using medication or undergone a procedure, they will always be at a better place in health than no treatment in the beginning. So give yourself, as a clinician, be it doctors, dietitian, surgeon, and also your patient, a pat on the shoulder, say that, well done, you have done your part with the evidence-based treatment options. Now let's see what else we could do to move forward together. Therefore, IFSO recommended 3 main strategies in managing recurrent weight gain. The first one is endoscopic procedure or investigation. Number 2, conventional or revisional surgery. And the third one is obesity management medication or OMMs. Of course, all these strategies addresses recurrent weight gain by helping patients to lose weight and inevitably put the obesity-related complication, the sun cow, into control again. However, there are times, right, when the obesity-related complication need to be addressed concurrently with the weight loss. So we couldn't just wait the blood pressure, the blood sugar to be in control while waiting for the weight loss to take effect. So we may need to independently treat these 3 conditions while the weight loss is coming. Because waiting may increase the CV risk. When patient having the blood pressure high for so long, then it may increase risk of stroke, etc. So these are my recommendation after review some literature on choosing the medication to treat these obesity-related and also CV event-related parameters. Choose those medication group that have weight-losing effect or if the worst case scenario, try to have it a weight neutral one. For instance, diabetes patients, we choose the GLP-1, GLP-GIP, or SGLT2 inhibitors. And if these are out of reach for patients, then choose SGLT2 inhibitors because this is the weight-losing diabetes medication. Try to avoid insulin, TZD, and sulfonylurea. As for hypertension, avoid beta blocker and calcium channel blocker because of weight gain risk. If beta blocker is needed, for instance, patient have history of IHD, we choose carvedilol because it's the most weight neutral. As for calcium channel blocker, if you need it to better enhance the blood pressure control, choose the non-dihydropyridine or the new type of calcium channel blocker like lecanidipine. As for dyslipidemia, there's no any study to link statins and azethamides towards weight gain. Moving forward, I just want to share a case that highlights how I manage a patient post-MBS recurrent weight gain. Not all about weight, but the recurrence of diabetes. Nancy is a 48-year-old lady. She works as a university administrator. When she first see me, she was 4 years post-sleeve gastrectomy, whereby she already achieved 25 kilograms of weight loss or 26% weight loss from her preoperative weight. In addition of losing good amount of weight, her underlying PCOS, dyslipidemia, and diabetes on insulin have all been in remission. So fantastic outcome from MBS. Over the last 2 years, she had gradual weight recurrence of 9 kilograms and diabetes was found to be recurred. Because of diabetes recurrence, Nancy is considered to have the recurrent weight gain criteria fulfilled based on IFSO, even though weight regain not more than 30%. So I started her on oral semaglutide 3 milligram while asking her to continue her great work in lifestyle changes. So Nancy weight regain is not because of lazy, lack of willpower. She already doing a lot of gym work 3 times per week and then eating healthily, adequate protein, but still regaining weight. Like I said, it's a progression of disease. Aside from occasional nausea, she tolerated the medication well over the 4 weeks and lost 2 kilograms in 1 month period. So I asked her to continue the 3 milligram oral semaglutide. And then she maintained another 2 months. Her side effects subsided and she agreed to maintain the medication for even longer duration. At the follow-up after 7 months, her weight has reduced about 3 kilograms. And she hoped to achieve more weight loss, so I asked her to increase oral sema to 7 milligrams to control her diabetes while losing some weight and see back in 4 months' time. So at this point, her diabetes already back in remission, HbA1c 5.7%. Nancy tolerated the higher dose of oral sema well, and there's no side effect at this point. Remember, from 3 milligrams, she had some side effect in the first 2 weeks, but when increased to 7, she tolerated well. So there are patients who are like that. It's all about monitoring and then explain to the patient. In total, at this point, she had lost 6.5 kilograms, and she maintained the medication for another 3 months, but then noted weight plateau. Despite that, her diabetes is still in remission. So due to cost issue, she wanted to try the oral semaglutide, 7 milligrams every other day. So I said, okay, let's do this. Unfortunately, after 3 months, she told me that due to cost issue, she need to discontinue the medication. At the same time, she said that I'm already at the weight plateau. I don't feel it's effective. So this is a misconcept. When you plateau, you should continue the medication long term because obesity, just like diabetes, is a disease. When we treat, we continue long term. So after that counseling, she said, okay, she's willing to try again the medication. And it's truly a chronic progressive disease. So let's see how it goes. Before I end, there are some take-home messages. Recurrent weight gain is defined not only by weight recurrence, but also the obesity-related complications recurrence, as per IFSO guideline. And recurrent weight gain is rarely due to a personal failure or surgical failure. It may just be aging, progression of disease, metabolic adaptation, etc. Management is so recommended 3 pillars management for recurrent weight gain: endoscopic procedure, revisional surgery, and also OMMs. There are times when concurrent treatment of the obesity-related complication and weight loss therapy may be required together. So when this happens, whether you want to treat the diabetes, hypertension, or dyslipidemia, choose the weight-losing regime rather than the weight-gaining one. Thank you, ladies and gentlemen, for your kind attention.
Thank you.